everyone. My name is Carly. For those of you who haven't met me, I'm going to be doing my clinical pearls talk. Okay, so here's our case presentation. We have a 40-year-old man. He was a restrained driver at an MDC going 30 miles per hour. He has no obvious injuries. Is AO times 3 on arrival, has stable vitals, but shows up in a cervical collar that EMS put him in. So he shows up looking at this and he's like, hey doc, can you get this collar off of me? It's really bothering me. You're the intern, you're like, I don't know, he looks fine, but what can we use to help make this decision? Thinking about this more, you're kind of talking about this case with your senior. Can we take this collar off of him? Your senior decides to use this as a learning topic and asks you some more questions. So your senior brings up, what if instead of 40, this was a 70-year-old man? What if he had been ejected from the vehicle? What if he had this huge right over and femur fracture? Or what if he was only ANO times 1? What if his clothes just reeked like alcohol? And how would each of those change your decision in clearing this patient's C-spine? So that's what we're going to be talking about today, clearing the cervical spine, and then a few other sprinkled in topics. So our outline, first we're going to talk about who needs imaging, then what type of imaging. We'll go through some cervical spine anatomy, and that'll lead us into a discussion about unstable C-spine fracture types, and then we'll summarize it all. So first, to image or not to image. Maybe luckily or unluckily, there are these two kind of well-defined clinical decision rules that can help us. I think it's really helpful for people at like lower levels like we are. We're still working with on developing our clinical gestalt to have these tools like in our toolbox. These tools are both very sensitive. They're both in the high 90s, which means that if you follow them, you're likely not going to miss any cervical spine fractures. But on the other hand, they're not very specific, so we're going to end up over-imaging a lot of people. And that's kind of just a risk benefit that you have to take, and knowing that in a serious injury, like a cervical spine injury, it's probably better to over-image some people. And then before we talk about each one, I just wanted to go into who these rules apply to and who they don't. So they only apply to adults between 18 and 60. With the Canadian C-spine, you can go a little older. They don't apply to direct blows to the neck, like if someone were hit in the neck with a baseball bat or something. And they also don't apply to penetrating neck traumas. So can't use these rules there. Okay, so let's talk about each one. I think the simpler one is the Nexus Criteria. It's pretty straightforward. And I kind of like to divide it into these two categories, mental status and secondary survey. So it says that if all of these conditions apply, then you don't need to image. So for mental status, if your patient isn't altered, if they're not intoxicated. And then for secondary survey, they have a normal neuro exam, they have no C-spine tenderness, and they have no distracting injuries. So for me, this is really simple because it really doesn't matter what happened before the accident. You can look at this patient in front of you and say, is their mental status normal? Is their physical exam normal? The only parts that get a little tricky are kind of what does not altered mean? The original authors just defined that if you had a GCS below 15, if you were disoriented to person, place, or time, if you were responding to external stimuli, then that would count as altered. If a person lost consciousness at the scene but is now fully altered, that doesn't count. That means they're altered now. They passed that test. The other complicated part is the no distracting injuries. Originally, they talked about this including long bone fractures, visceral injuries, large lacerations, crush injuries. But then they put this caveat in their paper. It can really apply to anything that you think could distract them from saying if they had cervical spine tenderness or not. So that's kind of up to your decision. And kind of looking at this, I think this kind of gives you reasons not to image. You can say, this patient looks normal, I don't want to image them. So it's kind of good to kind of back up your decision if you don't want to image them. Okay, so then the other decision rule is the Canadian C-spine rule. And this is a little more complicated and something that you might have to reference more frequently. So it involves these 3 steps and you have to go in order. So first it says you need to image all high-risk patients. So that means if your patient is over 65, if they have a dangerous mechanism, or if they have paresthesias, you have to image them regardless. The complicated part here is dangerous mechanism and what that includes. So they said it's a fall from 3 feet or 5 stairs or higher, if there is an axial load to the head, a motor vehicle collision greater than 62 miles per hour, which is easier to remember if you remember 100 kilometers per hour. If it's a motorized recreational vehicle, if they were ejected from the vehicle, or if it was a bicycle collision against an immovable object. So that's kind of like things you might have to think about in these like weird, like, oh, how often do we see people in motorized recreational vehicles? Something you might have to like re-look at, like what includes a dangerous mechanism. Okay, so that's the first step. Image high-risk patients. If you don't have a high-risk patient, you can go to step 2, which says don't image low-risk patients. So if your patient meets any one of the low-risk criteria, you don't have to image them. So if it was a simple rear-end MVC, if they're sitting up in the ED, if they were ambulatory, walking around at any time, if the neck pain didn't start right away, if it was delayed onset, and then if they have no C-spine tenderness. If you have any one of these, you don't have to image your patient. And then the third step, which you would, so you would go to the third step if you weren't imaging already. So the third step is you ask your patient to range their neck. They need to be able to go to 45 degrees on each side, and it's okay if it's painful, they just have to physically be able to do that. So if you're not high risk, you are low risk, and you can range your neck, you don't need imaging. So a little more complicated than Nexus. And kind of, to me, this kind of gives you reasons to image, because there's only like very specific criteria that a patient has to meet in order to not get imaging. Okay, but which one's better? They're actually both like pretty similar, and I think I'm a little too early here to kind of see what, it'll be interesting to see like what attendings and people use here. But when we're talking about sensitivities, they both have sensitivities in the high 90s. Canadians may be a little higher. Specificities are both pretty bad. Nexus is around like 12 to 35%. Canadians a little better in specificity, closer to 40%. But you can really use either. Okay, so going on to our second objective. We've decided that we need to image our patient, but what kind of imaging? And this is honestly like pretty straightforward. A CT scan is going to be so much better than an X-ray for clear C-spine. The sensitivity of an X-ray is about 52%, whereas a CT scan is going to be closer to 98%. So there's really very few reasons not to do the CT scan. More complicated is when your CT scan is negative, but you're still thinking about an injury. And so that's when you're going to need an MRI in order to see those tissues that a CT can't see well. And then this last point I made here, consider more imaging. So if you find a cervical spine fracture, it's actually very common that your patient's going to have another injury. So they recommend if you find a cervical spine injury, you actually need to image the whole spine. Also, 20% of cervical spine traumas have another injury in the body. So you need to kind of like think more about if your patient warrants more imaging. Okay, so then in order to just talk about specific fracture types, first we'll just review some cervical spine anatomy. So the concept people like to use is called the 3-column concept, and it's basically looking at anterior, middle, and posterior aspects of the spinal cord. And the idea is that if you have an injury in more than one of these columns, it makes your cervical spine unstable and more likely to cause a permanent damage to the spinal cord, because then the units can kind of move independently and cause more damage. And then just kind of remembering the nomenclature of our cervical spine. We have our atlas, which is C1, and our axis, which is C2. Your atlas fits into your occipital bones, and this is how you're going to move your head up and down. And then the dens process on your axis fits into this facet joints on your atlas, and that's how you're going to turn your head side to side. Okay. So there's a classification of cervical spine injuries called unstable cervical spine injuries. And these are the ones where if you see them, you need to basically get a neurosurgeon on board right away because you're really worried that your patient is going to develop damage to their spinal cord. We're not going to go over all of them today, just a few of them. The mnemonic to remember all of them is Jefferson bit off a hangman's thumb, which stands for a Jefferson fracture, bilateral facet dislocation, odontoid fractures. A is both atlanto-occipital dislocation and atlanto-axial dislocation. Hangman is just a hangman's fracture, and then the T is for a teardrop fracture. So we'll go over a few of these. The first one is a Jefferson fracture. So this is also known as a C1 first fracture. And it's often caused by an axial load to the head, and sometimes kind of on that line with a diving injury when you land straight on your head. And the idea is that the vertical compression kind of spreads out the force into those facet joints where your C1 connected to your occipital bone, and then causes these anterior and posterior arch fractures of C1. If you were to do an X-ray, you could see increased predental space, but it's also just pretty evident on CT as well. The next fracture we'll talk about is called atlanto-occipital dislocation, also known as internal decapitation. So this is basically with a severe flexion injury. You can actually get basically just tearing of your spinal cord here. If you were interested in defining it, you can use these Bayesian indexes to measure it and actually classify it. I'm not going to go into that, but I think it's good to know that that's how our radiologists may kind of classify this injury. The other thing that's interesting is that having Down syndrome can predispose you to this injury. So if you have a patient who has Down syndrome and is kind of coming in with these cervical spine complaints, it might be good to have it on your radar. Okay, and then the last fracture I wanted to talk about is called a hangman's fracture. It's actually very rarely seen with hangings, especially suicidal hangings. It's very rare there. You often see it in motor vehicle accidents, also in diving accidents. And it's caused by extension force on an already extended neck. So your neck going all the way back. And then it's a fracture of your C2 pedicle right here. Okay. So in summary, we talked about clearing the cervical spine. There are two good tools to do this, the Nexus and the CCR. Nexus, pretty straightforward, normal exam, no imaging, which means if their mental status, they're not altered, they're not intoxicated. And with your secondary survey, they have a normal neuro exam, they don't have C-spine tenderness, and they have no distracting injury, you don't need to image them. Our second tool is the CCR, which you have to go in this stepwise approach, which says if your patient is high risk, meaning they're over 65, it was a dangerous mechanism, they have paresthesias, you need to image them. If they're not high risk, you go to step 2. You say, is my patient low risk? Meaning, was it a simple rear end MVC? Is my patient up and walking around? Do they have no C-spine tenderness and a few other criteria? If you have just one of these, you can move on to step 3. If you don't have any low risk criteria, you need to image. So if you are low risk, you can go to step 3, which is asking your patient to range their neck. And if they can range their neck 45 degrees both ways, you're done with the pathway and you don't need to be imaged. With these, we have to remember our exclusion criteria can't be used in kids, can't be used in older people, over 60 for Nexus, over 65 with CCR, you're just going to image anyway. Can't be used with direct blows to the neck and can't be used with penetrating trauma to the neck. And then we talked about our unstable C-spine fractures, which have a high risk of cervical spine injury, spinal cord injury, and the mnemonic for that is Jefferson bit off a hangman's thumb. We talked about 3 of these, the Jefferson, which was our compression injury with the C1 burst fracture, the atlanto-occipital kind of internal decapitation from our flexion injury, and then our hangman's fracture, which is our fracture of our C2 pedicle from an extension injury. And that's it.
Just remember, for Nexus, it's midline tenderness, not lateral tenderness. But this does sort of take like some practice, and attendings are obviously much better at it than residents. So watch your attendings clear patients. I'll let the other attendings speak for themselves, but most of us use sort of a combination. I personally do Nexus first, but if they have a dangerous mechanism, then I'll image them anyway, and I'll throw in a couple other things from Canadian. But the other attendings say what they do as well.
I agree. I kind of combined them. Actually, I looked at the Nexus Criteria yesterday on MD Calc, and it was interesting. It was pretty cool. They had a whole interview with Jerry Hoffman about Nexus. That's something to check out. Comment. And I think, just like Dr. Silverberg said, remember it's midline. Something I like to do is before I start mashing on the patient's neck, if they say they have neck pain, I say, take your hand and show me where you're because you're going to start pressing on the midline and they're going to say it hurts, but if they can show you where they feel the pain, that can give you an idea. And I agree with Dr. Silverberg. It takes time to kind of gauge how risk averse you are and how much testing.
Unfortunately, I agree.
I have one more caveat that people who are rear-ended from behind, I don't believe I've ever seen a C-spine fracture next. The way they build cars now, they have a headrest. So when the car's hit from behind, your head snaps back when you hit the headrest, so you can't hyperextend it, and then you just kind of flat forward and get a muscular injury. But everybody has whiplash. They all want to sue. I don't think I've ever seen a fracture being hit from behind.
I think that's a big part of that's part of like that gestalt. Or like you see somebody at your end, I'm almost never going to see them.
Almost never.
No matter they're like, oh, it hurts when you do there. Honestly, I'll just call it paraspinal tenderness because it's so hard to have a significant C-spine injury after getting rear-ended.
Those low-risk criteria in the Canadian clinical decision rule are really good. You should add those to when you're evaluating a patient.
But it does say C-spine tenderness, and that's kind of like, that's usually the reason why we end up doing a CT, because they both, Nexus and Canadian, have midline C-spine tenderness. So that's really where the crux of the scale comes in, is determining whether or not they really have midline C-spine tenderness.
You don't have to have all of the low risk criteria for Canadian, so you could potentially clear someone who has.
Now, if you have any C-spine tenderness, you have to, according to Canadian, both Nexus and Canadian, if you have midline C-spine tenderness, it's a CT.
Yeah. That's where experience and you have to decide how risk averse you are. Fun part of medicine.
Watch your attendings clear people. You'll learn a lot from them because a lot of them will kind of mix these together.